So I'm going to talk about a less mature technique, and it's a way to access the aorta directly from the inferior vena cava. I want to point out that these are off-label or investigational techniques, and please don't construe these slides as marketing or promotion. Interesting backstory there. I also want to disclose that I've invented some technologies to improve on this that's been assigned to NIH, and my friend and colleague Adam Greenbaum has done the same. So this is what we aim for, is to access the aorta for TAVI directly from the abdominal inferior vena cava. It's pretty straightforward based on a CT plan. We take aortograms, we put a snare in the aorta, and we aim a crossing system into the snare like through a bullseye, and then we exchange for rigid guide wires like a Lunderquist to put our sheath from the femoral vein directly into the aorta, and afterwards we close the hole with a nitinol occluder device. There are a few published papers. I'm just going to give you a little bit of a taste today. It's pretty important to know that I don't think you should undertake this procedure based on this lecture or based on a little bit of reading. Please ask for some proctorship and some teaching if you think your institution should adopt this. So the patients should be selected who need TAVI, who are ineligible for transfemoral access, and who also are unsuitable for conventional surgical access. I'll point out that we are now doing an IDE trial using Amplatzer devices, even though Amplatzer devices aren't really well suited for this technique. Okay, so some fundamental underlying pathophysiology. You all know and assume that if you poke a hole in the aorta, you're going to exsanguinate in just a few seconds. What's pretty interesting is that what happens first is that the retroperitoneal space pressurizes. And if there happens also to be a hole in the vein, it's really interesting. This is counterintuitive. If there's a hole in the vein and a hole in the artery, the surrounding retroperitoneum tends to pressurize, and you will decompress that arterial hemorrhage very handily. And that's a fundamentally enabling principle to this technique. I want to point out another thing. It is really important to maintain that venous sink. If you have a hole in the aorta, but you have your sheath pulled out of the aorta into the intervening interstitium, you're going to cause a problem. It's really important that you have a venous sink or sump that's patent to allow arterial hemorrhage to return into the venous system. Okay, now step by step is what I promised Dr. Bernardo. For access, you get your traditional arterial pacemaker access. It's important to have a snare in the aorta. We like to go from the femoral artery that might be used for bailout. And we've all done these from the right femoral vein every time. We use full-dose heparin before we cross, and we choose heparin so that we can reverse it before closure. We place an electrosurgery unit, a BOVI. It's important to know where the ground pad is placed so that there are no interposed EP devices or metallic hips. Here are some of the key elements. You should have some training in proctorship and experience with VSD closure devices. You need a loop snare. An essential component is the Vascular Solutions piggyback wire converter. This converts an 014 wire to an 035 wire. An electrosurgery pencil. You should have an idea of how to tamponade the aorta in case you get into trouble. You should have a supply of occluder devices and a deflectable sheath. And it's nice to plan for a bailout endograft, although that's uncommon. We plan these procedures carefully based on a CT. You send it to NHLBI and my friend Marcus Chen, who is now running a Transcaval core lab, and we'll give you a plan that resembles this. We identify a calcium-free target. We tell you the projection angles. We tell you how big the aorta is to plan for an endograft. We tell you which lumbar target, for example, in this case, the middle of the third lumbar vertebra is where our target is. I'm sorry I have to be kind of rushed, but I want to give you a flavor. With a little bit of planning, this is a very straightforward procedure. Okay, so you have simultaneous aortogram and cavogram. It's nice not to opacify the mesenteric arteries. In this case, it was done with a crossing guiding catheter in the cava, ready for action. Straightforward. You with me? Nelson, you okay? Yeah. Okay. Okay. Then you prepare your crossing system. The crossing system is really simple. We take a guide wire inside a piggyback wire converter to make its outer diameter 035 so that we can deliver a braided microcatheter. In this case, I'm using brand names. I have no commercial conflict of interest. We use a braided Navicross so that we can get a rigid guide wire through there into the aorta. Now, one of the special tricks we play is we amputate the distal centimeter of a CTO guide wire so that it will not deflect. It will only go straight, and it's very stiff. And on the back end, making sure there are no short circuits, we just connect it to an electrosurgery pencil. We set it up at 30 to 50 watts, and we use only cutting mode. because we don't want to cauterize. Okay? Now, based on the CT target, we position our crossing system inside a renal guiding catheter in the cava, and we position a loop snare, an Amplatz gooseneck snare, into the aorta, just to position it as a target. We always go to the orthogonal projection predicted from the CT, and we position our crossing catheter where we want to be. If we know there's excess calcium on the posterior wall, well, then we aim away for it. Look at this scary picture. If we know that duodenum is interposed between cava and aorta, it's probably not a good target. In fact, it wasn't the case for this particular patient. But we take all these considerations in mind to choose our crossing target, and it's really simple. Okay. The crossing wire, when you electrify it, should really cross like butter. If it doesn't cross like butter, like this is bad. Something's wrong. And it turns out that calcium is really protective. If you can't get across, it's usually because you're at a bad target that has calcium. But there might be some other reasons, like you form some char, you have a short circuit in your wire. This is what it should really look like. It should go right through. In fact, you need to remember to turn off the bovie before you hit the left wall, the aorta. See that? How it buckles a little bit? Nelson, you okay?
Yeah. No problem.
Okay. Then, since you happen to have a snare pre-positioned as a target, if you snare the wire, you know you're in the aorta. And that's a great feeling. So everything is good. You snare the wire. Remember that the tip of wire is very sharp because it's been amputated. So you need carefully to steer that snare up. We actually drive it with a coronary guiding catheter. First, we pull up the 014 wire. Now we're pushing the wire and we're pushing the snare. Then we cross to the piggyback. The piggyback is just a fundamentally enabling thing. It's better than a balloon. See that piggyback goes across, and now we have an 035 rail in the aorta. Now we're holding on to the snare tip of the wire to make countertraction. And then once we have the piggyback in, we take a braided microcatheter and poke it into the aorta. Now we're really happy because now we can just pull all the stuff out and put a rigid Lunderquist wire into the aorta through that braided microcatheter. Okay? So then, in one step, we advance the TAVI introducer sheath into the aorta. Now, you obviously don't want this to happen. Pay close attention. It turns out that the trailing edge of the sheath can flare because it gets stretched in this way against calcium. That's bad, so you ought to do something. Twist your sheath or something so that that flare doesn't happen, because we can predict that to be injurious to the calcified aortic wall. This is what a good crossing looks like. Here's the tip of the sheath, and you can see it gets some resistance, and then it pops through into the aorta. Now, we stopped taking these aortograms because hemostasis is just universal. It's pretty nice, just like in the femoral artery, by the way. Okay, so we've done the TAVI. It's really interesting. Folks who've gotten bored with TAVI, this is an aortocaval procedure with an incidental valve implantation. Okay. Okay, so this part is also pretty straightforward, but you need to prepare. You prepare, you do the actual closure, and then you review and complete. Okay? When you prepare, you negotiate with your anesthesiologist so that you're all on the same team, and you want to warn the anesthesiologist not to overreact if pressure drops a little bit for a few moments. You reverse the heparin completely, early before you start. You have a recrossing system available, you have an aortic balloon system available in case you need it, and you need to make sure that there's an endograph somewhere in the hospital. To close, we place a buddy wire in case, heaven forbid, we pull our crossing system all the way through from the aorta into the cava. We position our occluder, we withdraw the TAVI sheath all the way into the vein, we'll take some pictures, don't worry, I'm going to show you some pictures. We position the occluder device, and then we look at the pictures and finish up. Okay. How do we choose the closure device? We have a very simple algorithm. If the aorta and cava are really close together, we know we can put a muscular VSD occluder device in, and the discs will reach from the aorta to the vein. If the aorta and cava are far apart, then then the venous disc would never reach the cava, so we use an Amplatz duct occluder. By the way, it's kind of similar to the way the duct occluder was designed to operate. If the sheath is big, we use an 8 millimeter VSD. If the sheath is small, we use a 6 millimeter VSD. Very simple algorithm. Okay, so here's our sheath from the femoral vein into the aorta. We place an 014 buddy wire, a very soft buddy wire. I'm sorry, it's getting dark outside. We expose the aortic disc. See that? Nelson, can I have another couple minutes?
Sure.
Okay.
Go ahead.
Okay. So this is a site that was being proctored. they were going pretty slowly. So don't go as slow as that. See, they just exited the aorta, and yet the vein is now occluded. So they're taking their deflectable sheath, the Agilis sheath, to position the occluder device horizontally, and only now did they pull the venous sheath back. It still worked out fine. You see what they did? But I would work faster. So then they push their pigtail up and take a picture, and you see there's a little fistula, but everything's cool. Okay? So the lesson here is move faster than this. I'll show you another example. Here, we pull the Agilis back. We have the transcatheter sheath in the cava. We've manipulated our pigtail up to take a picture. And again, you see another fistula. I'll show you that picture. A little aortic caval fistula. You know, sometimes the blood pressure drops from 110 to 100. It's not usually such a big deal. It's incredibly well tolerated. Okay, so then we retract the disc against the aortic wall, we straighten our deflectable sheath, and we form the occluder device. See that? Yeah. So this occluder device has been tugged so it can reach into the cava, assuming you're using a VSD device, or it just flaps into the breeze if it's a duct occluder and the aorta and cava are far apart. It's amazing that this works. Okay, so then now it's time to finish up the case. You want to review, remedy, and complete. Here's a digital subtraction angiogram. You see some aortic caval flow. You see a little extravasation. That's not good. You wouldn't leave that. Maybe the protamine hasn't completely gone in. Maybe you should do a little something. But the device seems adequately positioned, and the hemodynamics are completely stable. Here we're going to withdraw the buddy wire because there's pretty much nothing we're going to do. We're not going to put another closure device. We're not going to remove this closure device. We just need to play some tricks to obtain hemostasis. And the most common trick, in case there was a little bit of extravasation, is just to take a balloon. Often these aortas are very small because the typical patient requiring aortic caval access is a woman with small vascular access, and usually a 14 millimeter Fox cross will work just fine. Occlude that for 5 minutes or so in a heparin reverse patient, and that will usually solve all problems. You decide whether an endograft is necessary. You take another angiogram. Now this is a pretty bad result, I think, because here we see there's still some arterial bleeding, but there's no more contrast return to the vein. Instead, we have what we've demonstrated is venous disc occlusion without aortic disc occlusion. This should be remedied, and usually, again, just a short balloon inflation can remedy this for just 5 minutes, and then everything gets better. We take our completion angiogram, and this is a pretty good result. You have aortic caval flow. An aortic caval fistula is seen in the vast majority of patients undergoing this procedure. You also see this kind of cross-like cruciform pattern of contrast as contrast kind of spirals around the neck of the closure device. This is very well tolerated, and this is a site ready to complete. These are the typical patterns we see in completion angiography. The vast minority have complete occlusion, although when we use 18 French sheaths, these are more common. This is a patient with a duct occluder. You can see that the aorta and cava are far apart. The duct occluder is flapping in the breeze, and I don't know how this happens, but it's amazing. It's almost universal. There's a little channel that goes into the vein for this fistula, and these fistulae sometimes close after a few days or weeks. The most common pattern is the one that I showed you before, a residual aortic caval fistula with little contrast spiraling around the neck of the occluder device. But this pattern on the right is bad. This is frank extravasation, and you can't leave this. This patient will develop significant retroperitoneal hemorrhage and possibly hemodynamic instability. The first step is probably balloon tamponade, but I would have a very low threshold to put in a low-profile aortic endograft. So afterwards, they should be surveilled as are patients after EVAR with an arterial phase CT angiogram, both at pre-discharge, a month later, after a year. And to summarize, thanks for giving me a little extra time, so far there are about 80 patients that have been treated at about 14 medical centers in the last year and a half. I think we've learned that the technique is feasible, that it can be taught, and it's amazing that it works. We're sponsoring an IDE protocol using the Amplatzer devices, but again, I beg you not to undertake this without seeking some teaching and proctorship. We'd be happy to help you, especially if you can stack up a handful of cases. It's important to note that the closure is imperfect, as I showed you, using the marketed devices, because they're not designed for this indication. But I hope that with a purpose-built device, we might be able to offer transcaval access as an alternative to all surgical access when patients aren't amenable to transfemoral access. And this might have applications in other treatments, for example, in large caliber percutaneous LVADs or in thoracic aortic endografts. feel free to contact my colleague Anna Greenbaum or me if you have any questions. And thanks for letting me be here.